Have you ever wondered if an AI could give you medical advice? I mean, really reliable advice for something complex like managing a chronic condition.
Or maybe you're just curious, how these incredibly powerful new tools handle complex health stuff in general.
Well, welcome to the deep dive. This is where we take a stack of sources, could be articles, research, even our own notes, and we really try to pull out the most important insights for you.
And today, yeah, we're embarking on a really fascinating deep dive. We looked at a whole collection of interactions with different large language models.
Right, the big names, ChatGPT, Claude, Gemini, Grok, Copilot, DeepSeek, Perplexity.
Exactly. And we asked them a whole range of factual questions specifically about type 1 diabetes, T1D, and how you manage it day to day.
So our mission here is to pull out those critical nuggets from these, well, digital brains. We want to give you that shortcut to being really well informed.
We'll look at where they were remarkably consistent, where they offered maybe unique angles or slightly different points of emphasis.
And crucially, where we hit a really significant piece of, frankly, wrong information. It's a pretty stark reminder about, just blindly trusting AI for health advice.
Okay, let's get into it. Get ready for some, I think, truly eye-opening stuff on AI meets chronic disease management.
So where did you start? What was the first basic question?
We started right at the beginning. What is type 1 diabetes? And honestly, the answers showed this striking, almost unified front. It was quite impressive.
Really? Like across all those different models?
Every single one. They all correctly identified T1D as a chronic autoimmune condition, where the body's own immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas.
Okay, the core mechanism.
Right. And they all explain that this attack leads to little or no insulin production, which causes glucose to build up in the bloodstream. And, critically, that it means lifelong daily insulin therapy is needed just for survival.
Wow, that level of consensus on something so fundamental is, well, it's quite remarkable, isn't it?
It absolutely is. It suggests a really deep shared understanding of the basics.
But did that consistency hold up for other key characteristics?
It did. Beyond that core definition, they were equally unanimous on things like onset. They all noted, while it often starts in childhood or adolescence, it can actually happen at any age.
Okay.
And they agreed on the cause, too, involving a genetic predisposition, potentially combined with some kind of environmental trigger, maybe like a virus.
And I guess a really crucial distinction, especially for anyone new to this, is setting it apart from type 2 diabetes. Did they handle that well?
Perfectly. All the LLMs consistently highlighted that T1D is not preventable and it's not linked to lifestyle factors like obesity or diet.
Which is that key difference from type 2.
Precisely. And having that clarity consistently across all models on such a vital distinction, that's certainly reassuring. It shows they've got the foundational medical facts down pretty well.
Okay, so they nail the basics. But what about the day-to-day reality, the daily grind of managing T1D? What did they offer to make that easier?
Right. Moving beyond just the facts. When we asked for tips on easing that daily burden, the LLMs came back with, honestly, a wealth of practical and emotional strategies.
Oh, interesting.
And what's fascinating is how much of this advice really mirrored what you'd hear from, say, a real-world diabetes educator or maybe a support group.
So what kind of practical stuff stood out? What were the big recommendations?
Well, the truly game-changing insight, I think, from the LLMs about daily management was this unanimous emphasis on using technology.
Ah, okay. Makes sense.
Every single LLM stressed the power of continuous glucose monitors, CGMs, for that real-time tracking and seeing trends, and insulin pumps or smart pens for more precise, flexible insulin delivery.
Yeah, those tools have really changed things.
Absolutely. And many also highlighted various diabetes management apps. Beyond the tech, though, simplifying routines was another consistent theme.
Like what?
Things like meal prepping, trying to have consistent meal timings, establishing those daily diabetes check routines, just building structure.
You're getting organized.
Exactly. And for safety, keeping emergency snacks, glucose tabs, and like a go kit with essential supplies handy. That was a universal tip, too. Oh, and learning carb counting and label reading came up a lot for dietary control.
It's good they've focused on those practical tools, but,
Yeah.
Managing a chronic condition like T1D, it's got such a huge emotional side, too. Did they touch on that?
Oh, definitely. You're absolutely right. It's way more than just numbers and tech. On the emotional front, a key unifying message was basically, don't go it alone.
That sounds like good advice for anything tough.
It really is.
Yeah.
Seeking support from diabetes educators, your care team, support groups, whether they're online or local, that was consistently advised.
Mm-hmm.
Self-compassion also really resonated across the different responses, embracing imperfection, focusing on the overall patterns rather than every single number, and just being kind to yourself on rough days.
That's so important. It can be relentless.
It can. And a really nice unifying touch was the advice to acknowledge and celebrate the small victories, to build confidence and resilience along the way.
I like that. Did any of them offer sort of unique little life hacks or maybe surprising details that jumped out within those broader themes?
They certainly did. So while the main advice was broadly consistent, some LLMs gave these very specific, actionable details that were interesting.
Like what? Give me an example.
Okay, so DeepSeek, for instance, actually mentions specific app names like SugarMate or Night Scout for data tracking. Grok suggested using platforms like, formerly Twitter or JDRF for community insights.
Oh, interesting use of social media.
Yeah. Gemini focused a bit more on telemedicine and getting automated deliveries for supplies, sort of streamlining the logistics for patients.
Makes sense.
Copilot specifically emphasized finding foods that work for you and eating balanced, maybe lower-carb meals. And Perplexity actually mentioned specific courses by name, like DAFE, for learning carbohydrate counting.
Huh. It's like these nuances show that different LLMs might have slightly different depths of practical knowledge, maybe based on their training data, almost like little personalities peeking through.
Exactly. It felt a bit like that sometimes.
Okay, so we've covered the daily rhythm, but what about when things go wrong? Specifically, low blood sugar hypoglycemia. How did our digital guides handle that critical issue?
Right, hypoglycemia. When it came to treatment, the consensus was incredibly strong. It really centered around the rule of 15.
Okay, remind us what that is.
Sure, it's consuming 15 grams of fast-acting carbohydrates, then waiting 15 minutes, and rechecking your blood sugar. If it's still low, you repeat the process.
And were they consistent on what counts as fast-acting carbs?
Absolutely. All the LLMs gave consistent examples, things like glucose tablets or gels, regular soda, not diet, or fruit juice, sugar, honey, even hard candies.
Got it.
They also universally warned about the danger of overtreating a hypo, because that can just lead to rebound high blood sugar, which you also don't want.
Right, the roller coaster. What about really severe lows, where someone might need help?
Yeah, for severe lows, where a person can't swallow or they're confused, maybe even unconscious glucagon, either injected or the nasal spray, was the universal recommendation.
Followed by...
Always followed by calling emergency services, no question. They also consistently advised having a small snack, something with protein and carbs, after you recover if your next meal is more than an hour away, just to prevent another drop.
That makes sense. Stabilize things.
Exactly. And for prevention, identifying your personal triggers, maybe exercise, or delayed meal adjusting insulin doses with your doctor, and crucially, carrying supplies everywhere. Those were common, valuable strategies they all mentioned.
Within that strong consensus, were there any, intriguing variations or unique little tips that popped up from specific LLMs on hypos?
Yeah, a few distinct details did emerge. DeepSeek offered this unique pro tip, their words of considering a mini-dose glucagon for mild to moderate lows.
Mini-dose glucagon.
Yeah, the idea being it might treat the low without causing such a big rebound high. But importantly, DeepSeek strongly stressed you have to ask your doctor about this first. It's not standard advice.
Okay, important caveat. Anything else?
Gemini had some specific advice for people with kidney disease. It warned them to avoid orange juice for hypos, because it's high in potassium,
Oh, good point.
and suggested apple, grape, or cranberry juice as safer alternatives in that case. And Perplexity slightly adjusted the wait time. It said 10-15 minutes instead of a strict 15. And it gave slightly different numbers for how many glucose tabs might equal 15 grams, like maybe 5-7 instead of the usual 4-5. Minor stuff, but noticeable.
Interesting little variations.
Yeah.
Okay, let's switch gears slightly. Something that always seems to come up in discussions about diabetes and natural remedies is cinnamon. What did the LLMs have to say about that for type 1?
Cinnamon. This was maybe the single most consistent and definitive answer we got across all the LLMs.
Which was?
Unequivocally, cinnamon is not effective for managing blood sugar and type 1 diabetes. Full stop.
Okay, pretty clear. Why not? What was the reasoning?
Every single model explained why. T1D is an autoimmune disease, right? The pancreas produces little or no insulin. Cinnamon simply cannot replace that essential hormone. It can't stimulate production either.
Right. It doesn't fix the underlying problem.
Exactly. They noted that any sort of modest blood sugar improvements seen in some cinnamon research were primarily in people with type 2 diabetes, where insulin resistance is more the issue. And even then, they stress the evidence is pretty mixed and definitely not strong.
So the absolute bottom line, the non-negotiable takeaway here, is that cinnamon is not a substitute for insulin.
Absolutely not. Every model was crystal clear on that. Relying on it could be incredibly dangerous, leading to high blood sugar, hyperglycemia, maybe even diabetic ketoacidosis, DKA.
Were there other warnings?
Yes. Several warned about potential liver damage from taking large doses of cassia cinnamon, specifically because it contains coumarin. They also noted possible interactions with blood thinners or other medications. And a few even made the interesting point that if cinnamon somehow did have a lowering effect, it could actually increase the risk of hypos if insulin doses weren't adjusted properly, so it could even create new dangers.
Wow. So the message is loud and clear. Enjoy cinnamon on your toast, but definitely not for blood sugar control and T1D.
Precisely. Flavor, yes. Treatment, absolutely no.
Okay, moving on to another really critical area, eye health, protecting your vision. What did the LLMs advise if someone gets a diagnosis of background retinopathy?
Right. Background retinopathy. When we posed that scenario, the LLMs united again. Their primary recommendation was unanimous. Aggressive management of blood sugar, blood pressure, and cholesterol.
Okay, the trifecta.
Exactly. They consistently explained that background retinopathy is an early stage of diabetic eye disease. Tiny blood vessels in the retina start showing damage, but often without immediate vision problems yet.
Is there any good news there?
Yes, actually. The reassuring message, again consistent across the models, was that at this early stage, it's often reversible or at least manageable if you take action.
So what are the key actions? What do they emphasize most?
Tight blood sugar control. That was universally identified as the absolute most crucial factor.
Makes sense.
Targets often mentioned were around an HbA1c of 7% or less, or whatever your doctor advises, of course, and really minimizing those big glucose swings day to day. CGMs were specifically recommended again here to help achieve that stability.
Okay, so blood sugar first and foremost. What else?
Blood pressure management. Keeping that controlled, often the target mentioned was below 30-80 milli-Hg. High blood pressure significantly worsens retinopathy, so that was key.
Right.
And addressing LDL, the bad cholesterol, whether through diet or medication if needed, that was also a common piece of advice.
And checkups, I assume.
Oh, absolutely. All of them emphasized regular follow-up appointments with a retinal specialist or ophthalmologist, typically every 6 to 12 months, depending on the situation. And of course, the general healthy lifestyle stuff. Avoiding smoking, getting regular exercise, eating a balanced diet.
Within that advice, were there any specific facts or maybe surprising little insights from different LLMs about managing retinopathy?
Yes, there were some interesting nuggets. DeepSeek actually provided specific HbA1c improvement stats. It noted that even a 1% drop in A1c can reduce retinopathy progression by 35%.
Wow, that's a powerful statistic.
Isn't it? Grok reinforced that, citing findings from major trials like the DCCT and ADC studies, stating tight glucose control reduces progression by up to 76%. Huge numbers.
Really emphasizes the impact of control.
Definitely. Perplexity offered a specific HbA1c target 6.5% or below, if it's safe for the individual, but it also added this unique caution that a very rapid decrease in HbA1c can sometimes temporarily worsen retinopathy.
Really? That's counterintuitive.
It is. So it advised making gradual improvements rather than sudden, drastic drops. Gemini focused more on watching for specific symptoms like blurred or distorted vision, seeing floaters, or any sudden vision loss and reporting those immediately.
Good practical advice.
And Grok, interestingly, sort of linked back to the earlier hypo discussion. It advised managing hypos carefully to avoid those big glucose spikes afterwards because those spikes also stress the retinal blood vessels.
Fascinating connections. Okay, now, here's where you said it gets really interesting, where the consensus maybe starts to fray a bit.
Exactly.
Beyond insulin, which is obviously fundamental, what other treatments or therapies did the LLMs bring up for managing T1D? This is where the digital wisdom might start to diverge, right?
Yes, this section definitely showcased the most interesting variations and also different depths of knowledge among the LLMs. It really reflects how T1D management is constantly evolving.
But insulin is still king.
Oh, absolutely. They all reinforce that insulin remains fundamental, but then they offered a range of what you might call adjunct treatments and technologies.
Things we've touched on already.
Some, yes. They all reiterated the importance of CGMs and insulin pumps, especially the hybrid closed-loop systems, the artificial pancreas tech. They really emphasized those as a significant quality of life upgrade.
Because they automate so much.
Right, leading to better control, often with less daily burden. Diabetes education, mental health support specifically for burnout, and diabetes distress, and tailored nutrition and exercise planning were also consistently recommended across the board. Standard, good advice.
Okay. So what about specific medications besides insulin? What do they highlight there? What were the main cautions?
This is where it gets detailed. Most LLMs mentioned SGLT2 inhibitors. Those are drugs like dapagliflozin or empagliflozin.
Okay, what do they do?
They can help lower blood sugar, potentially reduce the amount of insulin needed, and sometimes aid with weight loss. However,
There's always a however with medications.
there often is. There was a significant and completely unanimous caution about the increased risk of diabetic ketoacidosis, DKA, with these drugs in T1D.
Even with normal blood sugar.
Yes, including what's called euglycemic DKA, which is DKA but with normal or near normal blood sugar levels, making it harder to spot. Gemini was particularly detailed here, noting their use is often restricted and requires really careful monitoring and patient education.
Okay, that's a critical warning. What else?
Another medication mentioned by several was the amylin analog, pramlintide, brand name Simlin.
What's the idea behind that one?
It works differently. It slows down digestion, which helps reduce those blood sugar spikes right after eating. It can potentially lower insulin needs and A1C too.
Downsides.
Potential nausea is a common one, and you need really careful dosing to avoid causing hypoglycemia, especially when starting it. Gemini also specifically pointed out it's approved in the USA, but generally not available in Europe.
Interesting geographical note. Any others?
GLP-1 receptor agonists. I think drugs like liraglutide or semaglutide, Ozempic, Wegovy, those types.
Aren't those mainly for type 2?
Primarily, yes. But Gemini, DeepSeek, Grok, and Perplexity brought them up for potential use in T1D, mostly for potential benefits in weight management and maybe glucose stability. Definitely. Gastrointestinal side effects, nausea, vomiting can be significant. And again, potential for hypoglycemia if insulin doses aren't adjusted carefully downwards. Gemini even went a step further, mentioning the newer dual GLP-1 GIP receptor agonists like tirzepatide, Mounjaro Zepbound, citing some promising early trial results, specifically in T1D, possibly with a lower hypo risk.
Wow, getting into the newer stuff there. One more.
Metformin. This came up from DeepSeek, Gemini, Grok, and Perplexity. It's typically the first-line drug for type 2.
Why mention it for type 1?
Primarily for people with T1D who also have some insulin resistance, which can happen, especially if someone is overweight. The idea is it might help stabilize glucose levels and potentially reduce insulin doses, generally without causing hypoglycemia by itself. Grok even mentioned a specific trial, the removal trial, in this context.
Okay, so that covers adjunct medications. This is where you said we see really different approaches, right?
Okay.
What about more alternative therapies or the truly cutting-edge emerging stuff?
Yes, this is where the LLMs really showed their different personalities or maybe databases. Copilot took a unique path here.
How so?
It was the only one to list alternative therapies, things like acupuncture, massage therapy, biofeedback, even specific supplements like alpha-lipoic acid and omega-3 fatty acids, listing them as complementary approaches. It did note research was ongoing, but it framed them quite differently.
And how did the others handle that kind of thing?
In stark contrast, actually, the other LLMs focus strictly on medically recognized adjuncts and technologies we've already discussed. Grok, for example, explicitly warned against unproven remedies like chromium, alpha-lipoic acid, or various herbal blends.
Why?
It stated they lack evidence for T1D and may interact with insulin or worsen hypos, basically warning against things without solid scientific backing for this specific condition. DeepSeek, interestingly, made a point of mentioning fiber-rich foods as a more reliable dietary adjunct than something like cinnamon.
So a real split there between Copilot's openness to complementary and others' stricter focus on evidence-based medicine.
A very clear split, yes.
And what about the really forward-looking treatments, the stuff that's still in trials or maybe just starting to emerge? Did any of them go there?
Oh, yes. DeepSeek and Gemini really shone here. They took the lead in detailing future and emerging therapies, giving a real glimpse into the research pipeline.
Like what kind of things?
They discussed immunotherapies, The goal there is to actually halt or maybe even reverse the autoimmune attack that causes T1D in the first place. They cited drugs like teplizumab, which aims to delay onset,
Wow, that's the holy grail, right?
getting closer. They also covered beta cell replacement therapies. This includes things like islet cell transplantation, taking insulin-producing cells from a donor, and also the really exciting work using stem cells to create new beta cells.
Still experimental, mostly.
Largely, yes, but advancing rapidly. Then there's smart insulin. These are insulin formulations being developed to only activate when blood sugar is actually high, which could dramatically reduce the risk of hypoglycemia.
That sounds amazing.
It does. They also mentioned verapamil. It's actually an older blood pressure drug, but some trials suggest it might help preserve remaining beta cell function in people newly diagnosed with T1D.
Repurposing existing drugs.
Exactly. And finally, they mentioned the bionic pancreas, specifically the islet system from Beta Bionics, which was actually FDA approved in 2023. It's a highly automated insulin delivery system.
So DeepSeek and Gemini seem to have a deeper dive into the research side.
It certainly appeared that way, yeah. They
Yeah.
offered a more forward-looking, research-oriented perspective on where the field might be heading.
Okay, now for the moment of truth, you mentioned a big learning moment, piece of information that was just wrong. Tell us about that. This sounds like the real wake-up call.
Yes, this was definitely an early and frankly quite alarming discovery in our interactions. It came from DeepSeek in its initial attempt to offer a clever tip, a pro hack, as it called it.
Oh,
It made a really terrible suggestion to freeze insulin pens or vials, the ones you're not currently using, as a way to extend their shelf life.
freeze insulin. That sounds fundamentally wrong. Insulin is a protein, right?
Yeah.
Freezing usually damages proteins.
Exactly. It's generally terrible advice. So, naturally, we challenged it.
And what happened then to double down?
No, thankfully. When challenged, DeepSeek immediately backtracked. It accepted that calling it a pro hack was wrong and that it wasn't good advice.
Okay, good. Did it explain itself?
It did. It then provided this very detailed explanation, sort of exploring why someone might even consider it. It mentioned things like maybe for unopened insulin only or for long-term stockpiling, or pointed to some older, often contradictory studies that showed some retention of efficacy after freezing and thawing under specific lab conditions.
Gotcha.
But then it followed up with the overwhelming risks and caveats. It stressed key points like never ever freeze opened insulin because the freeze-thaw cycle denatures the proteins, can cause clumping, and drastically reduces effectiveness. It said thawing must be gradual, absolutely no microwaves or direct heat. It noted that not all insulin types freeze and thaw equally well, with the newer analog insulins being potentially riskier. And a big warning for insulin pump users about the risk of clogging the pump tubing with damaged insulin.
So despite maybe some fringe discussion or old studies, what's the official word? What do manufacturers and health organizations say?
That's the crucial part. Manufacturers like Novo Nordisk, Eli Lilly, Sanofi, and official guidelines from bodies like the FDA and the American Diabetes Association unequivocally advise against freezing insulin
Why?
because of the potential for loss of potency, the risk of clumping and altered absorption, and the lack of standardized safety data to support it. DeepSeek, in its final clarification.
It's apology, basically.
Pretty much, yeah. It stated its initial suggestion was not a safe or reliable pro-hack. It emphasized that it had failed to emphasize the significant risks and lack of scientific medical endorsement, and it strongly discouraged anyone from doing it.
Wow. That's a huge mistake on a fundamental point of medication handling.
It really is. And this incident, happening early on, just underscores the critical need to always seek verification if you get an answer from an AI, especially about medical advice that feels even slightly off, or that you haven't heard before from a reliable source. You just can't take it at face value.
So let's pull this all together. After digging through all these interactions, what does this mean for you, the listener, trying to make sense of AI and health information?
Well, on the one hand, overall, these LLMs showed a pretty strong, generally consistent understanding of type 1 diabetes, the basics, the core management principles, even emergency stuff like treating hypos.
That foundational knowledge seems solid.
It does. There's shared advice on using technology, simplifying routines, building support networks, practicing self-compassion that all forms a really solid, reassuring base. And that unanimous, strong rejection of cinnamon as a T1D treatment, that was a particularly valuable piece of consistent clarity.
But the real story isn't just the consensus, is it?
No, I think the real story, the deeper insight for us, lies in those nuances and, importantly, the divergences. how the different LLMs varied in the breadth and depth of their advice, especially around those adjunct therapies and future treatments.
And there are different levels of caution, right?
Right.
Like with the alternative versus evidence-based approaches.
Exactly. And of course, that incident with the completely erroneous advice about freezing insulin, that really hammers home the point. Even on things that seem basic, we have to be critically aware and, frankly, a bit skeptical of the answers we get. These models are incredibly sophisticated, but they're absolutely not infallible.
So this deep dive really highlights a crucial takeaway point, doesn't it? While these LLMs are undeniably powerful tools for gathering information, maybe even summarizing complex topics, and they can offer surprisingly consistent advice on established T1D management.
They are not a substitute for your personal healthcare team. Not even close.
Right. Those nuances in their responses, especially when talking about newer medications or unproven remedies or things with significant risks like SGLT2 inhibitors, that just underscores why you always need to discuss any changes, any additions to your treatment plan with your own doctor, your endocrinologist, or your certified diabetes educator.
Because they understand you, your specific situation, your personal risks, your history. They can weigh the potential benefits against the potential side effects in your individual context. AI can't do that.
So the final thought for you, our listener, is really a question. How do you, as an informed individual, navigate this exciting but clearly complex new landscape of AI-generated information? How do you make sure you harness its power because it is powerful while always prioritizing safety and the irreplaceable value of human expertise? What stands out most to you from this dive into the medical mind of AI?